Hello everyone, myself Dr. Chirayu Vyas. This is one of a electrophysiology case which in the last year I'm presenting, which was one of my best experiences as to the surface ECG, which was showing a typical morphology of a tachycardia, which when assessed properly gave a very good result and an outcome of my electrophysiology EP study RFA case, which helped the patient very nicely. Starting with the case, this was the ECG with which the patient had presented a very fast tachycardia, which apparently was projected on ECG as most likely as a ventricular tachycardia, a VT, most likely in origin. And this is what once the patient had presented with pre-syncope and a systolic blood pressure of 90 millimeters of mercury, the patient was given a DC shock and was referred to me and sent to me from a hospital outside for conducting electrophysiology study, EP study and RFA. And that too also very interesting. Just we'll go for the next slide, which is what we'll just realize the facts. That this was looking like some ventricular tachycardia at around 240 beats per minute, was sent to me for an EP study RFA, but most importantly, utilizing the government scheme Ayushman Bharat Yojana at the private corporate hospital, which has got the attachment for this purpose and has also got the machinery for this purpose. It initially looked impossible, if at all, if it turned out as a ventricular tachycardia on a two-dimensional mapping system, which is what is available in the such a kind of government scheme, Ayushman Bharat Yojana. The patient was actually a 36-year-old male with no past history of an acute coronary syndrome, ACS. There was no structural heart disease with an LV ejection fraction of 60-65% on two-dimensional echo. A prior resting electrocardiogram ECG was in sinus rhythm with insignificant ST segment changes. And that's why this course was taken up for an electrophysiology EP study plus radiofrequency ablation RFA treatment in a two-dimensional mapping system at the corporate hospital, which is enrolled with the Ayushman Bharat Yojana scheme at Ahmedabad. And the most important reason for this criteria was the one which got it differentiated this wide QRS tachycardia as a SVT, supraventricular tachycardia with aberrancy. And that is what was a typical criterion which helped us in deciding this case, taking up for an electrophysiology EP study and RFA in Ayushman Bharat Yojana. This is what we conducted in the operation theatre, taking the femoral artery and the vein from the groin and putting the catheters from there after applying local anesthesia. And on the fluoroscopy screen, we just put the catheters at the right locations according to the signals which were picked up on the electrophysiology mapping system. And once we picked up the abnormal electrical circuit which was causing the supraventricular tachycardia with aberrancy, this is what we just treated by giving radiofrequency ablation RFA and got the patient treated completely. Actually, just basic in terms of how to do an electrophysiology study, this is what would show in the diagram as to the four chambers of the heart: the right atrium, the right ventricle, left atrium and the left ventricle, which is where the typical catheter locations as shown by the arrows, those are in usually the high right atrium HRA, then in the His bundle location, the His catheter, and at the right ventricular apical location, which is what these three are the main catheters which are used for the diagnostic electrophysiology study to study the origin of the arrhythmia and the pattern with which it is conducting. This arrhythmia, which was shown in the earlier ECG, it turned out as a right posterior accessory pathway with minimal pre-excitation on a resting surface electrocardiogram, which is what would be called as a Wolff-Parkinson-White WPW syndrome, with an inducible orthodromic atrioventricular re-entrant tachycardia, antidromic also the ART-AVRT was ablated by radiofrequency current at the posterior tricuspid location of the tricuspid valve annulus. Documentation of the removal of the bypass tract was done by checking a ventricular atrial conduction block in the presence of a right ventricular pacing, as well as blocking the AV node simultaneously with giving of an injection adenosine. This is what will be shown in the further slides. This is the slide which is depicting the surface ECG in the first 6 columns, lead 1, 2, 3, AVF, V1 and V6, which are what are showing the same kind of arrhythmia which was shown in the first ECG, at actually a higher speed. And importantly, the signals below are being shown in the intracardiac electrogram. The coronary sinus CS910, CS78, CS56, CS34. These are the electrodes which are from proximal to distal from 910 to 12. So 12 is the distal most tip of the catheter, and 910 are the proximal catheter electrode locations inside the coronary sinus, which is actually mapping the atrium. The next channels are his distal and his proximal. This is what quadripolar catheter is put in the right ventricle, which is what is assessing the ventriculogram. Along with that, the MAD-D and the MAD-U are the ablation catheter signals, which are just deciding as to at what point are we going to give the radio frequency current. This was the arrhythmia which ultimately got diagnosed as an antidromic reentrant tachycardia (AVRT) induced by the right posterior accelerated pathway. And these are the signals, which is what, if you can see in the prior ECG, there was 1:1 ventricular atrial conduction. If you just see the prior ECG, every wide QRS at the top is followed by a CS signal, which is what is actually the atrial signal. So every ventriculogram which was being paced pathway according to the presence of a ventricular atrial conduction block, which means the removal of the accessory pathway. That is what the patient got treated. And this was the ECG at end. The patient was discharged the next day in a normal surface ECG. So what we need to learn about this? This is what is the basic thing which I just wanted to project. That was a very, very interesting criterion in terms of a R wave peak time, RWPT, in lead 2 in a wide QRS tachycardia, which was considered as a new criterion for differentiating between wide QRS complex tachycardia 2010 in onset of R wave to the small, just a small duration, but it did achieve a small positive peak. This is what was the peak of the positive R wave in the QRS, which is predominantly negative, but the initial very minimal positivity was what was very important, and the onset of this QRS complex to the peak of that small R wave was called as RWPT, R wave peak time, which is what, when calculated in this lead 2, was pointed out to be around maybe 50 to 60 milliseconds at maximum, which is what is the classical criteria that if at all, if it is less than 50 milliseconds, this is what classifies it under the definition of supraventricular tachycardia with apparent conduction, which is what it turned out to be even on electrophysiology EP study. And considering that as a dangerous ventricular tachycardia VT, the procedure was not abandoned and was done even in a corporate hospital in the Ayushman Bharat Yojana government scheme, which is what got the patient treated permanently. Okay, thank you.